move on here and get this thing going again for you guys. Yeah, so your hematomas. So it's turning on. And just give you an example of a normal CT scan here and what you're going to see. And of course, generally you have multiple slices, right? So you have to look through all the individual slices. But any individual slice is more or less going to look like this here as soon as the projector pulls it up for you guys. Which, there, something like that, right? So an epidural hematoma is going to have this kind of this lens or a concave-like appearance to it. It's going to be white. Classic epidural hematoma. A subdural hematoma, yeah, like you guys have mentioned, kind of has more of kind of a crescent-like shape to it. It can also have what's known as a salt and pepper appearance, where you have old and new blood kind of mixed together, because subdural hematomas can take on an acute, a subacute, or even a chronic presentation, depending on what's going on with your patient. Good question there. Okay, let's just go. I want to review endocrine disorders real quick, because there are a lot of them and they're real easy to kind of get mixed up. So you have your thyroid disorders. So too much thyroid and too little thyroid hormone. So too much thyroid hormone is known as hyperthyroidism, also known as Graves. Good. I should be capital. And the life-threatening manifestation of that is thyrotoxicosis or thyroid storm. Okay. How do they look? Hypertensive, tachycardic, tachydysrhythmias, those kinds of things. Yes, hyperdynamic, heat intolerant, weight loss. Yeah. How about hypothyroidism? What's the life-threatening manifestation of hypothyroidism? Myxedema coma, right? How do they present? Quite the opposite as hyperthyroidism. They also have electrolyte anomalies, glucose metabolism problems, hypothermia as well. Okay, so that's the thyroid. Let's talk about the adrenal glands. Okay, specifically the adrenal cortex, right? Cortisol, right? Mineral and glucocorticoids come from there. All right, so you have Cushing syndrome, which is too much, right? Too much cortisol. How do these patients look? Well, they develop fat in weird places. They get the moon face, a buffalo hump. They get the striae, right? There's real notable stretch mark-like skin changes, right? They have glucose problems. They're going to be developing male pattern hair if you're dealing with a female that has this. Okay. They're going to have problems regulating water. They're going to be at risk for infections. Okay. And then what is the opposite of that? So adrenal insufficiency, Addison's disease, good. And does Addison's have a life-threatening presentation? Yes, Addison's crisis, right? Yeah, Addison's crisis. And this presents with what? Severe acute abdominal pain and hemodynamic compromise, right? Blood pressure gets low, they have problems with their blood sugar getting low, they can't regulate fluid and electrolyte balance very low. How do we treat them? We give them steroids, right? Hydrocortisone or Solu-Cortef. And occasionally people that take steroids, right? If they take steroids, long-term systemic steroids, if you stop their steroids, that may precipitate Addison's crisis. And so people that take large doses of systemic steroids, like people that have systemic lupus erythematosus or rheumatoid arthritis or maybe they have some sort of reactive airway or lung disease where they're taking lots of steroids, they can actually look like they can develop Cushing's syndrome, right, due to the exogenous steroids, and they can go into Addison's crisis if you withdraw them. Okie dokie, let's talk about the pancreas. You guys are good with type 1 versus type 2 diabetes. Type 1 tends to be, we think, autoimmune, tends to be associated with DKA. Type 2, the underlying mechanism is more insulin resistance. And hopefully you guys are good with all the complications associated with diabetes. There's a whole laundry list of them. HINC or HHS versus DKA. You guys okay with that? There are a few things that cause them. Clinically, they present pretty similar, except with HHS, you are not making ketones, typically not acidotic. And HHS can sometimes be treated very effectively with just fluids. They may not even need insulin infusions like you often need with DKA. Okie dokie, let's see. Are there any other major? Again, I'm trying to go for big picture problems here for you guys. Oh yes, the rare, pheochromocytoma. What is that? That's a good. Good. It's a catecholamine secreting tumor. It will present very similar to thyroid storm. Your patients will have a hyperthyroid presentation. The difference is they might not always be like that. With a pheochromocytoma, they tend to have like these cycles, right? When the tumor is actively secreting and when it's not, and so they'll have these cycles that can occur. Good deal. Good deal. Oh yeah. So let's talk about antidiuretic hormone problems. All right. So you can have too much ADH being released, and what is that known as? Good. SIADH, syndrome of inappropriate antidiuretic hormone. What is that? That causes us to hold on to water. Tends to dilute out our sodium. It can cause a dilutional hyponatremia, which can lead to cerebral edema, seizures, coma, death, badness. Inadequate amounts of ADH, known as diabetes insipidus, right? And that's where we insipidusly lose water, right? So how do we treat this? We give them ADH, right? What's the other name for ADH? Vasopressin, right? Nasal vasopressin. Right? And there are two forms too, right? There's the form involving the pituitary gland and central, I believe is what they call it. And then there's also what's known as the nephrogenic form, where your kidneys don't respond to the ADH. The nephrogenic form is going to be a lot more difficult to treat because they may not respond to the vasopressin given exogenously. Okie dokie. Just thinking about big picture stuff that we can go over. Anything else you guys can think of that you want to? You want to review?
The pituitary gland is the master gland, but the hypothalamus is the control of everything.
It's in control. Yeah. And if you're talking posterior pituitary gland, well, the posterior pituitary gland is just a direct extension of the hypothalamus, right? The anterior pituitary gland is its own gland, but it will only work when hormones get released from the hypothalamus, or so-called trophic hormones. I'm trying to think. Those are some of the major really important things. Just something off the top of my head. Are you guys good with the types of hypoxia? So. Histotoxic. Hyphemic, yeah. So hypoxic is classic, just low oxygen in the environment. Stagnant typically is due to pooling, right? CHF, cardiogenic shock, G forces, right? Prolonged exposure to G force. Histotoxic is poisoned hemoglobin, basically. And then hypemic is anemia. It's just a loss of oxygen carrying capacity. Okay, very good. What tends to happen as we increase in altitude with temperature? As we go up in altitude, temperature tends to what? Decrease.
Celsius every 1,000.
Good. 1 degree Celsius every 1,000 feet is kind of your
Well, Celsius right now, Fahrenheit.
Celsius, yeah. So it's like basically 2 degrees Fahrenheit, yeah. Yeah, good. I'm trying to think of any other concepts that you.
Will there be a lot of pediatric?
I don't know if there'll be a lot, but there'll be a little bit. You know, it was only one lecture, but it was kind of a long one.
OBGYN?
Yeah, there'll be some, yeah, again, there's only one lecture, it was kind of a long one. But again, hopefully you guys are familiar, right, with these conditions, a lot of these. So first trimester problems tend to be spontaneous abortions or miscarriages. Later pregnancy problems, placenta previa, abruption, different malpositions of the, breech presentation, eclampsia or preeclampsia, eclampsia, PIH, right, and some medications, gestational diabetes, good. What's that? HELP syndrome, good HELP syndrome is in there as well. Of course, magnesium sulfate plays a big role in managing some of these problems, seizures, blood pressure. Mag might be a good tocolytic. What is a tocolytic?
Decrease in reactions.
Good, yeah, to prevent labor. Okay. You guys go through phases of labor, those stages?
Phase 1 through 3, right?
Okay. Uterine atony is a big. What's uterine atony? It's kind of a big problem that we run into. It's following delivery. So atone, atony. A means without, tone, muscle tone. Where's that a problem? Following.
Contraction keeps bleeding.
Right, the uterus, right, yeah, the uterus, yeah, right. So boggy, we call boggy uterus, right? So hemorrhage, postpartum hemorrhage, right? So what are things we can do? Fundal massage, first of all, right? That's the first thing we should be doing, and then, yeah, even oxytocin infusions. Are you guys good with, let's see, there's some special terminology that we run into, paragravida. You guys should be good with that stuff, that's bread and butter. How about dilation and effacement? You guys okay with the concepts of dilation? It's how open the cervix is. Effacement is how thinned out. Station, right? Station is where the position of the head is in relation to the umbilicus. Okay, and there are some thresholds there, like there are some specific thresholds that they go with once they are dilated and effaced beyond a certain point, and that labor is pretty much inevitable. Let's see. Fetal heart tones, you're not going to have to answer electronic fetal heart monitoring questions, so you're not going to have a strip that's going to show you, oh, and you have to go, oh, well, that's a late decel or an early decel or a sinusoidal pattern, or anything like that. But in general, fetal heart, you want what, right or above 100, right? Greater than 100, right around 140, 160 with good variability, right? So it varies quite a bit. You don't like to see the heart rate decrease during contractions, because that can indicate a problem. Okay. Neonatal, so standard pediatric stuff, Boluses is a big one, right? Bread and butter, 20 mils per kilogram is your kind of your standard bolus for dehydration. Neonates, it's 10. You guys good with basic resuscitation as well? What's a pediatric assessment triangle? Appearance, work of breathing, and how they look. And that's basically, that's just as you're looking at them as you're making contact. Okay, good. I can't think of anything right off the top of my head unless you guys have. Huh? Oh, yeah, good idea. Let's talk about the balloon pump. Yeah, that's fair game. So, good. All right, so typically the timing is done where? What do we do our timing off of? The dichrotic notch, so our art line, right? So you have your art line here, and you have something that looks kind of like that. Okay. So what is this right here? That's the dichrotic notch. What does that indicate? Closure of the aortic valve. So that differentiates systole from diastole. Good. Remember, any invasive line, if we transduce it, where does the transducer need to be? Level the right atrium at about the fourth intercostal, right? Fourth IC. And that's known as the phlebistostatic axis. Good. And damping is something that we've talked about as well. Let's just go ahead and review damping, right? So air bubbles in the system is a big one. Kink tubing, transducer too high, transducer too low, right? And how do we check damping? We do the fast flush, and we got to do that on the monitor. Right, your fast flush, it should oscillate about 2 oscillations and return to baseline. If it oscillates more than that, that's under damping, and if it doesn't oscillate at all, that tends to be over damping. All right, so that's just quick down and dirty there. Okay, so there we go. So where does a balloon pump work? Yeah, so we know it's placed in the aorta, right, above what? Above the renal mesenteric arteries and below the subclavian. That comes off of the aortic arch. Okay, good. You've got radio-opaque markers on the balloon pump, so you got to get a chest film, right? Okay, so where does the balloon pump inflate? During diastole, so we typically use what? The dichrotic notch to differentiate between inflation and right? Or when to inflate. So we inflate it on the dichrotic notch. You guys good with that? All right, so it would inflate here, and then when does it deflate? Yeah, so at the end of diastole before systole begins, all right? And so it'll look something like that. So when we do our timing, typically we'll do like a 2 to 1 or 1 to 2. How do they put it? 1 to 2, I believe is, yeah. Yeah, it's every other beat's augmented. So you're gonna have something that looks like this. Okay, something that looks like this. Okay, so this is an unaugmented beat, and then this is an augmented beat. All right, so this is a dichrotic notch. You guys good with that? And you see how it inflated on the dichrotic notch there? Pressure went up, and then it deflates prior to the onset of systole, and it kind of has this U shape to it, and it goes below, the pressure goes below the baseline. Those are all things that tell us that we have good timing. And when we talk about timing errors, so what are our critical? So early inflation and late deflation. We talked about party etiquette. Okay, so early inflation, if I put my art line up here again, early inflation is inflating during systole before. And then late deflation is deflating while we're in systole. You guys okay with that? Those are critical errors. All right. Major problems, migration of the balloon, blood clots. If it fails, the balloon pump fails, what do we need to do?
Inflate with 16 mils of air.
Good.
Every 5 to 10 minutes.
Yeah, every 10 minutes or so, right? Inflate, manually inflate, deflate. Why? Are we doing that to augment the heart?
To keep blood clots.
Prevent clots from forming on the balloon. Good. If you see like a rusty, flaky, that could be a leak, balloon leak, right? Okay. Yeah. Helium mixing with the blood. What's going to happen typically as you have changes in altitude and barometric pressure to your balloon pump? It's going to stop, right? It'll stop and it'll reset itself to the new pressure. So you want to anticipate that if you're flying somebody and you have change in barometric pressure, the machine's going to stop, it's going to reset itself, and then it'll start back up again. So your patient might deteriorate while the balloon pump is doing that. So it would be. What kinds of special things do we monitor with the balloon pump? Anything special like pulse oximetry or pulse checks or?
Check bilateral blood pressures.
Good, bilateral blood pressures and bilateral SpO2 probes, right? Because if that balloon pump gets migrated too far up and you block the subclavian artery, you could block perfusion off to that limb, right? Likewise, you need to be monitoring perfusion of the leg where that balloon pump is inserted. And you're also going to need to splint that leg, right? You're going to splint it, right? Ideally put a pulse oximeter on the toe if you can, right, to monitor the perfusion. And you need to have a Foley catheter in these patients. We need to monitor their urinary output, because if their urinary output suddenly decreases, what might that tell us? Might have migrated down in the renal arteries. Good. With pulmonary artery catheter, I know I'm kind of skipping around, but what are some problems with misplacement of a pulmonary catheter?
Wedge.
So an inadvertent wedge, and you guys remember, so here is my pressure and time. So as I'm inserting the pulmonary catheter, I'm going to get a waveform that looks like that. That's my my CVP waveform. Yeah, and then it might go up a little bit in the right atrium, and then I'm going to get something that looks like this. I'm in the right ventricle, and then pulmonary artery, and then wedge. Okay, so where should we normally be when we're not doing anything with the pulmonary artery catheter? What should it normally look like? Yeah, I should have a normal pulmonary artery pressure. If this happens during transport, inadvertent wedge. So how do we correct that? What do we need to do?
Hold back.
Pull back? What do you mean pull back?
Or have them cough.
No, not for wedging. It's the first thing we need to do. Deflate that damn balloon, right? Make sure the balloon's deflated. And remember, we need to have the special 1.5 milliliter syringe. Take that with us. Yeah, so make sure it's deflated. That's the first thing. And then there are other things like pulling it back, you know, if you have to. The other problem is you're transporting and then you see this suddenly happen. Your patient starts developing PVCs, maybe runs a VTAC. What has happened there? Migrated back into the right ventricle. So what are some immediate things that we can do that might correct this? immediate things. So have the patient cough, have them change their position, right? Those are the first things we do. And if that doesn't, then, you know, as a last resort, you pull the catheter back until you get a central venous waveform there. Cool. All right. Good. I'm glad that came up, because that's good basic troubleshooting there. How long should we wedge? Then
30 seconds.
30 seconds? 15 seconds, yeah. Absolutely no longer than 15 seconds. How much air do we put in the balloon if we're going to wedge?
1.5 or less.
Right, yeah. We don't put 1.5 milliliters. That's the absolute maximum. We only put enough air to cause a change, right? Once it changes to a wedge waveform, we stop, we get the wedge pressure, and we drop the balloon again. Good. Okay. When we're changing,
Chris,
huh?
inflation of the balloon should not be longer than 15 to 30 seconds.
Okay. Good. 15 to 30, all right.
That's where I got my numbers.
All right, good. So they go up to 30. That's kind of a long time, but okay. You know, fair enough. That's what they go with, so we'll go with that. Good. Oh, what was I gonna say? I was saying something. Oh, yes. When do we zero our invasive lines?
Patient
Position,
moves.
patient movement.
At altitude.
Major moves and changes in altitude. And generally speaking, there are basically at least 3 times that we're going to have to zero. We're going to have to zero at patient contact, zero at altitude, and then zero once we land. All right, good. Good, I think we're good there. What do you guys think? Does that seem like we've hit some of the major stuff that we need to talk about? Do you guys have anything else? Any other?
So chest tube insertion for air is second intercostal space, midclavicular.
Go high, yep. And then
for
fluid, blood, trauma,
mid-axillary.
mid-axillary, fourth IC in there. Good. Yeah. Cool. I know, it's a lot of stuff, isn't it? When you start thinking about it, it's a lot of stuff. Good deal.
You know, there's gonna be a lot of stuff on congenital heart defects and
Maybe a little. I don't know, I don't know exactly. But yeah, cyanotic versus acyanotic, right? Which one's shunt? Your cyanotics generally require acyanotic to survive, right? They generally require shunts. So we may need to give them things like prostaglandin infusions, right? To keep the PDA open. We might need to keep them a little hypoxic. Oftentimes, how do they present? CHF, right? A lot of they have CHF-like signs and symptoms. Okay. Anything else, guys? I don't think so.
so the FFPs can be given as fast as the patient can tolerate.
Pretty much, yeah. You do have to do a type and screen on those.
No, I'm in 4 hours.
Signs and symptoms of transfusion reaction, right? Know that. How to react if there's a transfusion reaction. Yeah. Okay, well, you guys want to get out of here? If you feel like we've kind of reviewed what we need to, or we've done the major stuff, I'll get you guys out of here, and then I'll see you tomorrow with your patches.
Yes.
Yeah,
Yes, you will.
that's right. That's right.
And I tattooed you on my head. I heard you already got that.
That's right. That's right. That's confidence there. I already got the tattoo.
So you'll call this up later on?
Yeah, I'm gonna start uploading the videos today and put them onto Canvas for you.